So good morning, good afternoon, good evening, everyone. My name is Rajesh Tatoud, and together with my two co-hosts, Linah, Kampilimba, Mwango, and Festus McKean, it's a pleasure to welcome you all to this Science After Hours webinar dedicated to HIV research and development. It is the third event in the series of independent online events aimed at engaging with communities around HIV prevention, treatment, and cure. Today, our session will focus on long-acting antiretroviral for HIV treatment, and we are greatly honored to have a very special guest joining us today, Dr. Rajesh Gandhi, Director of HIV Education, Division of Infectious Disease, Massachusetts General Hospital, also Vice Chair of the ACTG and Professor of Medicine of Harvard Medical School. Our session will include two short presentations and a longer presentation followed by question and answer. Now I would like to hand over to my first co-host, Festus McKean, who will share his perspective on long-acting antiretroviral for treatment, or they might change the life of people living with HIV, and what challenges may arise from their use. Festus, over to you.
Okay, thank you so very much, Roger. Hello, everybody. So my name is Festus, and I'm an HIV vaccine advocate, a fellow of the IS 2024 HIV Vaccine Advocacy Academy, and I'm the executive director of Minority Voices Liberia. I want to share today some of our groundworks, and so in 2024 we completed an integrated biological and behavioral surveillance survey in Liberia, which happened across 5 counties in the country, and we were looking at we covered men who have sex with men, female sex workers, people who inject drugs, and transgender women. What we found was very sobering. Among MSM in Liberia, HIV prevalence was at 19% for MSM. Among transgender women, it was over 21%. And these are not just abstract numbers. These are our community members, people who are already carrying enormous stigma and data burden. But what matters the most to me is the promise in relations to long-acting ARVs is that, the promise of an injection for 1 or 2 months instead of daily pill will be very transformative for me and for my community. It will ensure less visibility at health facility. It will reduce stigma. It will potentially be better for adherence. Not because people are more disciplined, but because, treatment might fit the reality of our day-to-day lives. But what really concerned me is that long-acting ARVs will require people to come back regularly at health facilities or at drop-in centers for injections. It also requires that, we have more trust in our health system. It also requires stable infrastructure. It also requires community outreach. And to be honest, in Liberia, and as in many settings across Africa, we still need to build those foundations of trust within those various areas. So today, I am here with an honest concern that the science of long-acting treatment is exciting for me, for my community. But if we don't address access to stigma and the broken care cascade at the same time, we will risk creating another innovation that works beautifully in trial, and it might barely reach the people who need it the most. Because what we see based on our recent integrated biological and behavioral surveillance survey in Liberia that we did in 2024, we saw the HIV prevalence in MSM was at 19%. Amongst transgender women, it was over 21%. And these are not just abstract numbers. These are my community. Real people. So it's very interesting. What is complex about this is that we realize in the survey when we reach out to the MSM community, we realize that over 53% of the MSM who participated in the survey has undergone a family rejection. Transgender women have experienced verbal harassment. We've seen that people who inject drugs have been arrested more than once. So people who face those level of discrimination in everyday life, keeping to daily pills, it's not just a logistical challenge. It is an act of survival for us. So for me, the ARV should not just be the long-acting ARV should not just be like the daily pill, like the PrEP, uh, but it should be something that change our approach and promote more adherence. So thank you so much for this opportunity.
And if you would like to take the spot and tell us about what long-acting antiretroviral means in your practice.
Thank you so much, Roger. And as already introduced, I'm Linah Mwango. I'm the technical director at Ciheb, Zambia, which is a local Zambian non-governmental organization that has been working with the Ministry of Health in supporting health systems as well as managing vulnerable populations such as adolescents and key populations that are usually marginalized when it comes to HIV service delivery. Yeah. So long-acting injectables really present opportunities as well as challenges that are associated with it. Of course, in our setting, these new treatment options present a major advancement in HIV care because they have the potential to reduce the burden of daily pill taking, improving adherence, as well as enhancing the quality of life for people with HIV. For many clients, especially the adolescents and key populations, as well as those that are highly mobile, injectable treatment options may provide greater convenience, privacy, as well as improved treatment satisfaction. However, despite all these benefits, long-acting injectables come with challenges as well, and these need to be addressed before successful rollout as well as scale up. One major challenge is the health system capacity. So unlike the oral ART, long-acting injectables require stronger infrastructure, adequate clinic space, as well as trained healthcare workers who can safely administer injections as well as monitor the clients that are receiving the injectable ARVs. And in our setting, many facilities, particularly in the rural communities, already face challenges such as staffing shortages, limited space, outstretched services as well. So introducing these new models of care without strengthening the health system may also place additional pressure on the current healthcare facilities. And also another important challenge to note is the need for regular clinic visits. While the oral ARTs can be dispensed for several months, and of course, we have person-centered care models whereby these oral ARVs can be delivered right in the community or in the comfort of the client, injectable long-acting ARVs require extra resources, such as a person has to actually move from where they are to go into a health facility, and injection administration is a sterile procedure. So really decentralizing and providing these services outside a health facility may come with its own challenges. And of course, because of the distance that recipients of care need to cover to access these services, there's also a cost factor that goes to the recipient of care that has to access this. Of course, supply chain is another thing that needs to be factored into the health system. It's also a very critical consideration. Long-acting ARVs require highly reliable supply chain systems so that there is avoidance of interruption in dosing schedules. Many countries must also invest in also healthcare worker training because we need to capacity build the healthcare workers. And as we know, we need to make sure that we're also keeping track of how the clients are responding. So we need to have sustained laboratory system that can do this. And since these products are more expensive than the standard oral treatment, sustainability remains a key concern, particularly in most of our setting where we rely heavily on donor funding. So community acceptance as well is another issue, as well as equity. So these must remain central to implementation efforts. There's actually a need for a strong community engagement and health education to address misconceptions, as well as build confidence in these new treatment options. At the same time, we must also ensure that there's equity in terms of access, as these new options usually would target people that are living in urban settings, and always the ones in the rural settings are left out. So in summary, long-acting ARVs present a promising opportunity to strengthen HIV treatment outcomes. However, successful implementation will require investment in the health systems, workforce, supply chain, as well as capacity building and sustainable financing. Over to you, Roger.
Well, thank you for having me today. My name is Raj Gandhi. I'm at Mass General Hospital, as you've heard. I've been asked to talk a little bit about the landscape of long-acting antiretroviral therapy for treatment. I want to thank a number of people who helped me.
My apologies, Dr. Gandhi. It's not the right screen. It's the preview.
Okay, let's try one more time. We'll get this right here. And how about now?
Yeah, perfect. Thank you.
Okay, great. I'm planning to talk for about 25 minutes with the intent that there be a good opportunity for questions and comments. And I really appreciate the comments that were just made. They're very, very important around the practicality of long-acting therapy. But let's talk a bit about the options that we have and think about that together. So we're going to try over the next 25 minutes or so to see the future. And I'm going to try to cover three topics briefly. Why do we need new antiretroviral therapy? The bulk of the time is on some of the newer drugs, ones we have now, but also ones that we may have in the near future. And then how will we use these new injectable therapies? And when I say injectable, let me pause and say, I'm going to talk about injectables, but I'm also going to talk about some oral long-acting options, because there's some of the logistic things that were just mentioned about setting up systems. If we had oral long-acting therapy, that would also make it more practical. So just as a background, antiretroviral therapy should be started as soon as someone is diagnosed with HIV, and regardless of CD4 cell counts. This is now well accepted. I'm part of a group called the IAS USA, International Antiviral Society USA. And we put out guidelines about a year and a half ago. We're updating these guidelines, but this is now well accepted. These are the regimens used most commonly in the United States. One of these, the middle one, is used worldwide, but bictegravir, tenofovir, emtricitabine is broadly used. Dolutegravir plus tenofovir lamivudine or emtricitabine, TLD, is used globally. And then occasionally, less commonly, dolutegravir with lamivudine, two-drug therapy is used. And my understanding is Botswana and some other countries in sub-Saharan Africa are thinking about, or maybe even planning to, go to two-drug therapy. And if people are interested, we can talk about that as well. That's not specifically related to long-acting. So with this as background, why do we need new antiretroviral therapy in the US? There are more than 30 drugs approved for treating people with HIV. The three that I mentioned are the most commonly used, but all of these treatments do still have some limitations. We've learned in recent years that antiretroviral therapy can be associated with weight gain. There are still some important drug-drug interactions, particularly with TB drugs like rifampicin. Daily oral dosing can be a challenge for people who are particularly vulnerable. So daily oral dosing is the mainstay of therapy now. So if we had a less frequent dosing, that might help people who are having difficulty with daily oral dosing. There is some concern about drug-resistant HIV, in particular dolutegravir resistance, and then the high cost of drugs is a challenge for all of our regimens. So I'm going to give you three examples of the types of things that we need, and hopefully long-acting therapies will fulfill some of these needs. For someone doing well on antiretroviral therapy already, there's still an interest in fewer drugs that have less toxicity. There is a benefit, I think, to reduce dosing frequency to some of these individuals, high barrier to resistance, and safety during pregnancy. For people, though, who are struggling with daily oral ART, I think the reduced dosing frequency is the impetus, is the rationale for long-acting therapy, and then that in turn may actually help reduce stigma and reduce visibility if someone is taking therapy every 2 or even every 6 months. And then finally, for people with multi-drug resistant HIV, having new medicines that actually work against drug-resistant HIV. This is not the majority of people with HIV, but they're a very, very important group of people with HIV, and we want to make sure that new drugs we develop are able to help those individuals who have virus resistant to our current treatments. So those are the 3 areas that we need new drugs for. Let's talk about the drug that right now is used in the US and some parts of the world. It's cabotegravir rilpivirine. Just as a reminder, cabotegravir is an integrase inhibitor. Rilpivirine is a non-nucleoside reverse transcriptase inhibitor. This particular injectable is administered every 2 months. It's injected into the gluteus medius, so it is administered in a clinical setting. We were just talking just now about the settings in which therapy is given, and right now these are not self-administered injections. It is approved in the US for people who already have suppression of HIV with oral therapy, but I'm going to show you some data that it actually looks like it's of benefit for people who are struggling with daily oral therapy, but its FDA approval in the US is for people who have HIV suppression already. The study that I think there's a series of studies that have really opened up the landscape. One is a study that was published in the New England Journal of Medicine a few months ago. It's called the Latitude study. This particular study was done in people with HIV who were having difficulties taking oral antiretroviral therapy. All of these study participants were treated with oral antiretroviral therapy until their HIV was suppressed. And then half of the participants were switched to long-acting injections, and half continued on oral therapy. And what I'm showing you here is a graph from this paper showing you the rate of regimen failure. The injectable group, the cabotegravir rilpivirine, had a rate of regimen failure that was substantially lower than the people who continued on oral therapy. And so the conclusion is, in this vulnerable population of individuals who are having trouble taking oral therapy, that injectable therapy improves outcomes, improves virologic suppression rates compared to oral antiretroviral therapies. There's a number now of demonstration projects looking at people with HIV who are not yet on effective antiretrovirals. These are individuals who are viremic or have HIV replication, high viral loads in some instances. I'm going to give you 2 examples. One is in San Francisco, 129 individuals. The HIV suppression rate with injectable therapy with cabotegravir rilpivirine was 98%. And then in a very poor part of the United States, Mississippi, 12 participants, HIV suppression rates of 100%. So there are more and more experience with injectables for people who are not yet on oral therapy with suppression. So I'm going to give you my own perspective on the use of injectable therapy, cabotegravir rilpivirine, in people who have HIV. For people whose HIV is well controlled, their viral load is undetectable, their viral load is suppressed, and they do not have resistance. Almost everyone will stay suppressed after switching to injectable therapy. I don't show this, but the CARE study that many of you know, done in sub-Saharan Africa, really showed us very high rates of virologic suppression in excess of 95%. There is, though, a small risk of drug resistance. It's worth being aware of that, counseling people about that, but it is a very small rate in people who start with virologic suppression, with HIV suppressed. For people who have resistance, right now I usually choose a different regimen if they're able to take oral treatment. When we talk about the future, we should come back to resistance. And I will point out in a moment a study that we hope to start that may be important for people with drug resistance. And then for people at high risk for HIV complications, particularly those who have a low CD4 cell count of less than 200, and if they're not able to take oral therapy, we are offering injectable therapy alongside addressing the barriers to engagement in care. So that's kind of my own practice here in the US. 2 studies I want to call out that we hope to start this year. One is a study they're both studying cabotegravir, the injectable integrase inhibitor given every 2 months, with lenacapavir, a drug that Many of you are aware of this. Is an every 6-month treatment that's being used. It's a drug that's being used for prevention, but it's also approved for treatment. Conjoining cabotegravir plus lenacapavir may help us get beyond the issue of resistance, because lenacapavir is not compromised by people who have resistance to older drugs like efavirenz, non-nucleoside RT inhibitors, which were the drugs that we used for many, many years throughout the world. So there's a study being done in the US called PALACE, which is looking at cabotegravir plus lenacapavir for people who have resistance to older drugs, non-nucleoside reverse transcriptase inhibitors, and a study that we plan to launch in sub-Saharan Africa called Lancet is also looking at cabotegravir, the integrase inhibitor, plus lenacapavir for people who are having trouble taking oral medicines. I'm hoping that there'll be interest and questions about these two studies that we'll talk about during the Q&A, because we have a lot of excitement about these options. So now I'm not going to talk about where we are today, but I'm going to talk about where we hope to be. And I'm going to tell you about some drugs that we're very interested in hoping to see develop. But let's start with how the virus gets into the cell, because these drugs work on the virus as it gets through the cell and creates new copies of itself. So HIV enters our body cells through the CD4 receptor, but also what's called a co-receptor. In the US, there are several approved drugs that block entry into the cell by the virus. Something you've heard about, I suspect, broadly neutralizing antibodies. These are antibodies that work on the entry step of HIV and thereby prevent HIV from replicating by preventing it from getting a foothold in the cell. Once HIV gets into the cell, the virus itself, the RNA of the virus is reverse transcribed into DNA. The drugs that we've had for many, many years, the nucleoside reverse transcriptase inhibitors, the first of which was AZT, but tenofovir is a reverse transcriptase inhibitor. These work on that step, the RNA to DNA step. Some of the newer drugs that you'll see talked about in the future, one is called islatravir. Islatravir was just approved in the US in the last few weeks. This is a nucleoside reverse transcriptase translocation inhibitor, but it's working in that same part of the virus. And then tenofovir I mentioned, AZT I mentioned, but efavirenz I mentioned. These are all reverse transcriptase inhibitors. There's a newer long-acting reverse transcriptase inhibitor called ulonivirine that's on the horizon, still in studies. Once RNA is reverse transcribed into DNA, then integrase inhibitors, of which dolutegravir is the best example, cabotegravir is another. These block the DNA becoming part of the cell's DNA. And so there are newer drugs, newer integrase inhibitors on the horizon that work at the same stage. Once the virus is in the person's DNA, then it's made into proteins, and the protease inhibitors, of which Kaletra or lopinavir as an example, darunavir as an example, they work on that part of the virus life cycle. And then finally, lenacapavir, a drug, as I mentioned, being used for prevention, is also used for treatment because it blocks that last stage of what's called the capsid. So those are the drugs, and those are some of the new drugs that are being studied. I won't go into detail because they're some years off, but the ones in red are the newer drugs. Some of them just have names, and some of them just have letters and names because they're too new to have words. I'm going to just point out a couple of drugs that were approved recently. There is a drug called doravirine, which is in the same class as efavirenz. It's being combined with islatravir, the nucleoside reverse transcriptase translocation inhibitor. They block HIV replication. Just about 3 weeks ago in the US, this combination was approved to replace other treatments in people whose HIV is already well controlled. It's the first daily pill without an integrase inhibitor, but it is daily. It's once a day. It's a stepping stone, though, I think, to weekly therapy. There is a combination of islatravir, the same drug I was mentioning that's approved for daily therapy, that can be given weekly along with lenacapavir, not by injection, but by mouth. And this particular weekly combination has gone through the initial stages of testing with promising results. And we hope later this year, 2026, we may see the results of larger definitive studies that may lead to the availability of weekly therapy. Again, many people will do well with daily therapy. We'll talk about that. But for people who would do better for weekly therapy, this might be an option in the future. Now, I'm going to take a step back and say, I think oral therapy, when we get to the Q&A, I think for most people, oral therapy is still going to be the preferred. Now, there's some people who do prefer injections, but some people prefer pills. And we all know the reason why people prefer pills. You can get reactions to injections. Some people prefer to avoid needles. Some people are taking other medicines already by mouth. Why not take another medicine for the HIV? And then right now, most of our injections are being done in clinics. Some people will prefer to take therapy at home and not come to a clinical setting. I want to just say one word about broadly neutralizing antibodies, one or two words about this, because these are promising. These are antibodies that the body makes that can then be developed into a medicine that neutralizes a broad variety of HIV strains. So the technology is advanced so that you can find these antibodies and then develop them into medicines. The way these antibodies work is they bind to the virus itself, and then they prevent the virus from getting into the cell. And if it can't get into a cell, then the virus can't replicate. The reason why these are of interest is even if people's virus is resistant to drugs like dolutegravir, drugs like cabotegravir, the broadly neutralizing antibodies should still work. They target the virus directly. They seem to be quite safe, and they're being evaluated for treatment, but they're also being evaluated for prevention and even for trying to cure HIV. So really a lot of interest in these broadly neutralizing antibodies. And now I'm going to put on one slide a lot of the things that people are interested in for the future. So I've already mentioned weekly therapy. Islatravir plus lenacapavir is furthest along. It's in phase 3 clinical trials, which are the last stage of trials. So weekly therapy. Islatravir is also being combined with ulonivirine, weekly therapy. But let's go beyond that and think to the future. There are monthly therapies. I'm going to show you in a moment one of the drugs that's being studied for prevention, MK-8527, is now in phase 3 clinical trials, which is the last stage of trials for monthly PrEP. There's also an every 4-month combination of cabotegravir with rilpivirine, but new formulations. The broadly neutralizing antibodies I was just talking about are being studied every 6 months. And then I'm going to show you in a minute, there's a once-a-year formulation of lenacapavir for prevention that is being studied in clinical trials. And then finally, I'll mention implants. So a lot of things we hope coming that will give more options for the future. Let's just say a word about PrEP right now. Pre-exposure prophylaxis, there's daily pills, daily oral therapy. Tenofovir with FTC is one option. There's also on-demand options, which means taking tenofovir FTC around the time of sex, 2 pills before sex, one the day after, one the day after that. And then finally, people are aware of long-acting injectables for treatment, but they're also being used for pre-exposure prophylaxis. Cabotegravir just by itself can be given every 2 months for prevention. And then lenacapavir last year is becoming available, hopefully globally, every 6-month dosing of lenacapavir. I mentioned things on the horizon. This is the monthly pill. Just at the retrovirus meeting this year, which is the big HIV meeting, we learned that once monthly MK-8527 is now in phase 3 clinical trials, and it has a very quick onset of action within an hour, so that's an advantage. And then lenacapavir currently is dosed every 6 months, twice a year, injected subcutaneously, but there are some promising data with injecting lenacapavir into a muscle rather than under the skin with very good drug levels. And this is being evaluated in a study called Purpose 365, once a year, not here yet, but something we hope for the future. Okay, a couple of words about implants, and then we'll begin to wrap up so that we can have a discussion. Implants, I would say, are further off. Implants in women without HIV was not well tolerated. In fact, there were local side effects. So something we don't have yet. A different drug implant has been tested in mice, but obviously there's a big difference between mice and humans. So this is further off. We have implants, of course, for contraception. Wouldn't it be nice if we also had an implant for HIV treatment? But this, I would say, is not in the immediate future, but something people are working on. And I can imagine a day, if it works, where we could combine contraception with implants for HIV, but I think that day is still a ways away. So now let's talk about how we will use these new long-acting treatments. I think in the US, we're mainly using them for people who are having difficulty with oral daily therapy. But for most people, I anticipate oral daily therapy is going to remain effective and convenient. For long-acting therapy, I think it's a good option for people who struggle with daily oral regimen or who just don't want to take a medicine every day. And we're looking into combining visits for these long-acting injections with other appointments, medical appointments. In the US, substance use disorder is a big problem. So methadone refills, psychiatrist appointments, health centers, kind of decentralizing care, I think was mentioned. We're going to need to do that, I think, if this is going to be successful. Some of the considerations I want people to think about with long-acting ARVs, the dose levels linger for months. That's the whole point of long-acting ARVs. So if someone misses a dose, they may need oral medicines temporarily. That's going to create some challenges. People may need reminders to stay on schedules. There's just the physical space where we're going to administer these drugs. It's not always easy to find. Managing side effects if they develop. What to do if a recipient becomes pregnant. Some of these drugs haven't been well studied in pregnancy, although thankfully lenacapavir and cabotegravir both look safe in pregnancy. What to do if a medicine is required that interacts with long-acting drugs. Here I would put out tuberculosis as the big issue because rifampicin does affect drug levels, for example, of cabotegravir. And then case management support and other support features to help people who are having trouble with adherence. For people with resistance, this is a patient of mine whose virus is resistant to really all the currently available oral drugs. That is not common, but it is occasionally a problem. And for those people, I would say these newer drugs, several of which are approved, but not all of which are approved, may really offer hope for people with MDR HIV, multi-drug resistant HIV, because these newer drugs they still seem to be active against virus that's resistant to older drugs. What about cost? This may be something we want to give some really good attention to during the discussion. These novel agents may not be cost effective if the price is too high. And I will say there's a need to advocate. Some of you are working in advocacy to price these drugs to ensure access to people in countries around the world. Within this decade, it's anticipated that 4.5 million people in Africa will need second-line therapy, and some will need these novel drugs for drug-resistant HIV. So here's my last slide. Why do we need new drugs? We need to overcome the limitations of current therapies with fewer drugs, less frequent dosing, activity against resistant HIV. Some of the new drugs that I've shared with you target novel mechanisms, things that we're not targeting right now. There is a pipeline of long-acting agents, but we do need to develop better access and delivery systems. Again, rural settings was mentioned just now. That is something we have to really attend to. And then finally, how are we going to use the new drugs? And this will be a launching point to our discussion. Really depends on the person and their needs, but for all people with HIV, we do need to redouble our efforts to provide more options, to reduce costs, and to ensure equitable access around the world. So I think I've stayed within my 25 minutes. I'm going to stop sharing my slides so that people can see each other. And I'm very happy to take any questions, but also very happy to take any comments.
Thank you very much. Right in time, a very comprehensive presentation and a very comprehensive landscaping. You talk about a lot of new drugs, and I think hopefully we'll have some question and time to discuss a bit more about that.
And thank you so much again, Dr. Gandhi. I would just want to ask a question. Do you think long-acting ARVs are suitable in all contexts and settings? Thank you.
Thank you for that question. Do I think long-acting ARVs are suitable in all settings? I think we should work or strive towards giving the option of long-acting ARVs in all settings. And just as you and others have said, the logistics, safe delivery, rural settings, these are all things that are challenges, but obviously we have overcome challenges before. There's some unique challenges with long-acting therapy, the infrastructure to give injections, which is why I and others keep an eye on the oral landscape as well, because the oral landscape doesn't come with logistical considerations, but unfortunately, the oral drugs thus far are at best weekly to monthly. We don't have an oral every 6 month option on the horizon. But I think we should work towards making the options available. But how we get there is going to be something we should talk about. I think, in fact, I think that's the reason we're talking today, is to figure out some of these are coming. How are we going to get them to the people who need them most? And how are we going to do so in a sustainable fashion? I mean, the world came together, as we all know, and this is not right now. The world is, I think, sometimes appears to be falling apart, but the world came together around TLD and global access to HIV, and that did change, the discussion. I've been in HIV since the 1990s, and things really have changed since then. Can we get to a decade from now, 20 years from now, so that they're even better than they are now? I think so, but it's going to take people on the ground really telling us and thinking about how do we get there. So yeah, I hope that answers your question.
Thank you. Before you move on, Festus, I'd like to ask a question based on what you said, but I think which is important, and one of the concerns you raised, and both Dr. Gandhi and Linah can probably help us better understand that. You talk about the need to come back regularly, and indeed, if you think about long-acting, like people having to come back every 6 months, it's a very different follow-up and engagement with people living with HIV than if you have to come back every month or every 2 or 3 months to get your pills. So I'll ask first, Dr. Gandhi, is that also a concern you have, and how? And then I'll ask Linah, what can we do to ensure people come back?
So speaking from my perspective, the majority of my patients still take oral ART. In fact, I would say 90%, maybe even 95% of my patients still take oral ART because they're doing well on treatment. They like the convenience of picking up the pills themselves and don't want to come to my clinic every 2 months, because our current treatment is injections are every 2 months. But for the 5% of people, 5 to 10% of people who have difficulty taking a pill or just prefer not to think about it every day, there are people who just don't want to think about their HIV every day. For them, they are generally doing well, and they are also retention is quite high. The experience in San Francisco that I mentioned, of 100 people or so that they gave long-acting therapy, 5 ended up going back to pills, but the other 95 stayed on injections. But if you think about it, those were people who wanted to get injections. For those people who want to get injections, 90%, 95% prefer to stay on injections. But we do have the option of going back. One point to make here is, if you start injections and you're doing well, and in the future your life circumstances change, you move to a different area, it is safe to go back on oral pills. You haven't, as we say, burned that bridge, or you haven't left that behind. And that's a good point to reinforce.
Linah, what do you think in your setting about having to call back people every 6 months, making sure they come back?
Okay, so like I mentioned earlier on, the health systems need to be really strengthened and prepared for this. As Zambia, we've started long-acting for prevention, and we started with cabotegravir, and now we're doing lenacapavir, 6 monthly. But there's a lot of things that need to go in to make sure that recipients of care do continue engagement in care. One of them is the active tracking. As you may know, for cabotegravir, you have to make sure that they receive the scheduled doses in a timely manner. And I think there is need for a lot of community education, and of course, using person-centered care models like social network testing strategy or social network outreach strategies, where we have fellow network members engaging and making sure that, especially for the hard-to-reach population, are retained back into care and they continue receiving treatment. And like I mentioned earlier on, for oral antiretroviral drugs, it's much easier because you can even do community delivery into the community, so that you just keep people engaged. The the other side where you have to give injections, you need to have people physically come through and receive their dose at a health facility. So investing in systems like tracking systems that will keep clients engaged, especially for the longer acting, like the 6 monthly, where like on a monthly basis, there's like a contact with a recipient of care and just to check on how they're doing, and of course reminding them on the importance of them really coming back and continuing. So I think those are some of the things that need to be put in place. I would also like to understand, how do you choose, how do you decide which client takes oral treatment and which ones take injectable treatment in routine care?
So in routine care, most of our patients have started with oral therapy, and some of them are coming to us saying that they either prefer to take injections, and luckily we do have the option of offering the injectables, or other people are saying they not only prefer to take the injections, but they're having trouble remembering to take the pills. In the US, it's often in the setting of either stigma or people not wanting to share with their families that they have HIV, or just don't want to, take a pill every day. Or equally often, or more often, it's people who have depression, anxiety, mental illness, or people who have substance use disorder, where taking a pill every day is a challenge. So I would say it's those I would say about half the patients are taking it because they prefer to take an injection, and the other half because they're just not able to take a pill every day. It's not really there's just too many other things, considerations going on.
Yeah, thank you. And Roger, if it's okay, I
carry
just
on.
I just want to pick up from one of the things that Dr. Gandhi mentioned. In terms of attrition, what are the main challenges for users, especially attrition? What are some of the things they have brought up, especially those that want to go back to oral, and as well as are there any adherence issues in terms of appointments that are scheduled for them?
Yes, the adherence issues we worried a lot about early, because the worry had been that if someone gets an injection and then doesn't come back, that the drugs will slowly come out of their system and that resistance will occur. I would say that most of the people thus far who have started therapy, because they have been very, they go into the therapy because they really want it. Our general experience has been that they have been coming to regular appointments. What they say to us, though, is having to physically come to the clinic. Also in the US, some people live at quite a distance from the clinic. They find that to be very burdensome. And so the people who have switched are usually switching back because of the burden of coming to clinic, or there can be injection site reactions. Most of the time with cabotegravir rilpivirine, the injection site reactions are fairly short-lived, a few days, and fairly mild. Lenacapavir, those of you who have used PrEP, lenacapavir for PrEP, a fairly substantial number of people develop nodules at the site of the lenacapavir injections, and those nodules sometimes can last for weeks, if not even months. That's because the drug itself, the lenacapavir, comes out very, very slowly from the site of injection, and that nodule essentially is a depot. It's where the drugs are coming from. So those nodules, most people don't find them bothersome, but some people do. And so as we roll out cabotegravir with lenacapavir for treatment, we'll see, what the experience is with the lenacapavir. I would say the majority thus far. I have a few people on cabotegravir, lenacapavir for treatment, and they are generally doing quite well. So.
Thank you. Let's try to see if Festus is back. I really want him to have a chance to ask a question.
Yes, thank you. So, Dr. Gandhi, my question is, should long-acting ARVs be primarily targeted to specific populations? For example, adolescents, pregnant women, or people with adherence challenges?
You asked such a good question, to which I think it's very difficult to give a definitive answer. We had a workshop about a year and a half ago where that was exactly the question that people were grappling with. And I will tell you there's two views on this, and then I'll tell you my own view. One view is it should be prioritized for people like adolescents, pregnant women, and people with adherence challenges, because the logistics of giving injectables to 39 million people around the world is so large that it would be a mistake, some people think, to not really focus it on the people who need it most. And I have a lot of sympathy for that perspective, because it is not simple, even in a resource-rich country, to administer these injections. We have about 100 people on injections, and it does take quite a bit of time. Some of the clinics have 600 or 700 people. It takes a lot of time for the nurses and the navigators, patient navigators. Now, if you talk about not 600 people, but if you talk about thousands, tens of thousands, hundreds of thousands, you can imagine the logistics. So I would say the priority, the thing that we should focus on first, is developing long-acting injectables for people who are most vulnerable, the people that you just said, adolescents, pregnant women, people with adherence challenges. I think in the future, though, having an option so that people have told me, and you'll tell me yourself, that even though pills, most people are doing well, it's also not, there's not a small number of people who take pills for a period of time and then have challenges or something, they either move or something else comes up, so that pills themselves come with their own challenges. So if we could get to a time where it was an option for people beyond just the most vulnerable, I think that would be doing our patients a service. People talk about contraception as an example. I understand that contraception is not the same, but the fact that there are both pills for contraception, but also implants and injections, it gives a person much more autonomy, I guess is the right word, in terms of how they get their care. Could we do the same for HIV? I think that should be a longer term goal as we get the most vulnerable people suppressed. So, yeah.
Thank you. I'm going to ask another follow-up question because it relates to the drug themselves. But
yeah,
how crucial is it that these new ARV are also efficient or effective against hepatitis B and compatible with TB treatment? Because you mentioned it, and that will allow me to ask another question in relation to that and to resistance. So it's a two-part question: the efficiency against other viruses which current drug have, and then the emergence of resistance, and what do you do to prevent the emergence of resistance, and what do you do if it happens? So that's three questions, sorry.
Yes, multifaceted. Let's start with hepatitis B. So as being alluded to, tenofovir, a drug that we use widely in TLD, does have hepatitis B activity, and therefore not only does it treat hepatitis B, but it also prevents hepatitis B. And so all these combinations that we've just been talking about, including some of the oral combinations, islatravir, doravirine, which was approved recently, do not have tenofovir, and therefore we have seen people who have, one of two things has happened. Some people develop what we call reactivation of hepatitis B. That is, they had hepatitis B, it was being treated by tenofovir, and then when they stop the tenofovir and go on to injectables, the hepatitis B resurfaces, and occasionally it can be quite serious. We've had even a few people who've had fulminant liver failure and even some deaths. It's not common, but it can happen. And then we've also seen people separately who don't have hepatitis B, they've acquired hepatitis B. In the US, where vaccination for hepatitis B is broadly available, one of our steps before we give long-acting injectables is to try to ensure that people are not infected with hepatitis B. We do a surface antigen for hepatitis B, which I do believe is pretty broadly available. But if they're not immune to hepatitis B, if their surface antibody is negative, we offer and we strongly recommend that they get the hepatitis B vaccine. I would love to know from the people on this call how widely available is hepatitis B vaccine for adults, not for children, but for adults. That's hepatitis B, important consideration. If you have it, these long-acting injectables come with that disadvantage. In terms of the second question was around resistance, is that right? Oh, let's do TB first. Tuberculosis is so yes, cabotegravir levels are affected by rifampicin, and so are lenacapavir levels. And so I know there's work going on to try to adjust lenacapavir dosing with rifampicin. Right now, today, I think the challenge would be if someone needed rifampicin, they would need to be able to be transitioned back to oral therapy. And so again, people working in TB endemic areas, people on this call should comment about the logistics of that, but that is another limitation. If we had drugs in the future that were not metabolized in the same way and were not affected by rifampicin, if we're looking to the future, that's another need that the field has, which is a long-acting injectable or a long-acting oral that's compatible with TB therapy. And then the last point about resistance, I think the big challenge here is cabotegravir is an integrase inhibitor, and if people have breakthrough of their virus on cabotegravir, they will almost certainly be resistant to dolutegravir. And that's going to become a... Now, I will tell you that there's a little bit of experience with people who've acquired HIV on cabotegravir PrEP, where they were able to get suppressed on TLD. There's only a handful or maybe two handfuls of cases, not more than 10, where people who acquired HIV on cabotegravir PrEP did get suppressed with TLD, with dolutegravir, tenofovir, lamivudine. But I think right now we still need to know a lot more about what are our options if people have breakthrough on injectable therapy. I don't think we have a good answer to that today. So.
Thank you. Linah, would you like to comment or to respond either on Hep B or TB, your concern, your view?
Okay, yeah, so I think Dr. Gandhi did mention about adult Hep B vaccination. So I think for Zambia, we only have it free for the healthcare workers that are working in the public hospitals. And I think Ciheb Zambia has been supporting the Ministry of Health to protect the healthcare workers in the public facilities. So we're providing Hep B vaccination. Of course, this was initially a pilot intervention, and we're moving now to full scale. Yeah, and also the other comment is around protection and also, prevention and treatment for Hep B. We see that TDF provides that, and Dr. Gandhi mentioned, the long-acting injectables really do not have that. So yeah. And TB screening, for us, we live in an area where TB is quite high because of overcrowding and a number of people being homeless. So it's really also something critical to even consider as a country decides to move in the direction of long-acting injectables.
Thank you. We have 2 minutes, 1 minute, 2 minutes, and I really have two questions. One, because we have to talk about it, is cost, and I will not talk about it directly, but I will ask the question, what would it take to convince policymaker, funder, financer, Ministry of Health to move to long-acting, which currently are expensive compared to TLD, which is very cheap and works rather well?
Mm-hmm. It's a good question. I think we should do an entire hour on this. That's probably not possible to do in a minute, but I will say that that is exactly the kind of discussions that need to happen right now. We should be planning for success, but we need to do it deliberately and figure out the cost effectiveness. And I think that's why probably it will start for the most vulnerable, as people were saying. But yeah.
Thank you. And I'll try to bring Festus one more time. Are you looking forward for long-acting antiretroviral, Festus?
Well, so for me, in my advocacy, I'm very optimistic. I keep pushing every day, but in reality, long-acting ARV is not, I know, a major topic under discussion in our healthcare system and in our national HIV program. We just completed our national strategic plan, which is going to guide us for the next 5 to 7 years. And I was amazed while in that meeting that with stakeholders from international partners and local CSOs in the room, bringing about the conversation about long-acting ARVs was introducing something new to the discourse. But notwithstanding, what I believe can happen is more engagement, more dialogues with stakeholders, like our government policy, to ensure that this is actually going to help us, especially with the current change in global health affairs across the world. So I'm optimistic. I'm hopeful that it's going to happen, even though it's going to come with some challenges, of which with oral PrEP, thing that we can be able to deal with and see us approach zero new HIV infection and HIV by 2030. Thank you so much, Roger.
Thank you. 10 seconds, Linah, a final word, and then Dr. Gandhi.
So
Thanks.
yeah, thanks so much. And final words, there are more benefits to using long-acting injectables, but we need to look at financing, we need to look at sustainability, and we also need to look at workforce development. So it's an exciting area to think of, but before we move into those lines, we need to consider those factors. Thank you.
Dr. Gandhi?
I'll say the same. We've confronted big challenges before. This is an opportunity, as was said, but I think it's going to need to come with this kind of deliberate discussions. I think this discussion is a good launching point, but I think more to come. And some of the things that were highlighted are really critical as we think through this deliberately. So.
Thank you very much to all of you. Apologies for the technical problem. It was a great beginning, a great discussion. I hope we'll have more. And I wish you a very good evening and a very good day. Thanks all again. Bye-bye.
Thank you very much. Take care.
Thank you.